Hi, my name is Katie Staley, and I'm a senior program officer on the immunization team at the Gates Foundation. And today I'm going to share a bit about the insights that we've learned from our routine immunization strengthening program, also known as RISP. I'm going to share a lot about the great things that RISP has done and some of the things that we're really excited about in terms of lessons learned. But I'm also going to be pretty candid about what's not working as well and what challenges we've had in terms of designing programs to reach zero dose and under immunized kids. So a little bit of background on RISP. RISP is a program that we started in 2019 to improve routine immunization in subnational geographies of 10 countries that have low Penta 3 coverage and that are also at high risk of polio transmission. So RISP works in complement to polio eradication efforts, but I want to underscore that our focus is on improving routine immunization. We don't do campaigns within RISP. We have four sub-goals. The first, as I just mentioned, is to complement efforts to reduce poliovirus circulation. The second is around improving routine immunization coverage. The third is on sustainability, and I'll talk a little bit more later on about what that means in different contexts. And finally, our fourth goal is really about what we're here to do today, which is to share lessons learned and insights from our work to be able to support the full Gavi Alliance's understanding about working in zero dose and under immunized settings. So like I mentioned, RISP works in the subnational areas of 10 geographies. And while we tailor our approach to each one of those subnational geographies, we have three broad archetypes that we tend to follow. On the left-hand side of the slide, you can see our first archetype is our MOU work. And in the MOU settings, we really work through government systems to directly strengthen those systems for improved RI operations over the long run. One core component of this model is the financing element, in which the government develops its RI operational budget, and we co-fund those operations directly into a government-owned basket fund. And then we also provide TA support. If you skip down to the bottom part of the left-hand side of the slide, the next model I want to talk about is our direct service delivery work. And this is mostly in humanitarian or conflict-affected settings. And in these settings, we work within humanitarian partnerships to support local service delivery partners to reach kids, often in areas that have suffered from chronic insecurity for several years. And then finally, the hybrid approach, which we employ in Pakistan, is a little bit of a mix of both, in which we do direct service delivery support while also partnering very closely with provincial governments to transition those new service delivery points to government over the long run. And I'll also mention that while the insights that I'm sharing today come largely from our internal team lesson learned, we also have a formalized RISP learning consortium that is just finishing its year one learning loop. And so we will have additional insights to share from that by the end of the year. So diving in, I've got 5 key lessons that I want to share today. And the first comes from the MOU settings that I mentioned. So I think the key lesson that we have learned in these settings is that there are 3 elements from our theory of change that have been really instrumental to seeing success. The first is having a clear and targeted plan, and I'm going to use DRC as an example here. So in DRC, there is a government-led and multi-partner supported routine immunization strengthening plan called the Mashako Plan. And that has very clear targets. It is supported by multiple partners in a coordinated way. There is a nationwide monitoring system and a lot of visibility on the progress made under the Mashako Plan. And we think that this kind of high-level concrete plan with goals and attached monitoring is really important to rally both financing, advocacy, and improve service delivery improvements behind one plan. The second piece is that within the provinces that we support under the Mashako Plan, we use a memorandum of understanding tool to really partner with those provincial governments to provide clearly agreed upon technical assistance and other support to achieve the goals within the Mashako Plan. And finally, the third piece is really around high-level advocacy. We use presidential level forums as political engagement opportunities at the highest level, not just with the Ministry of Health, but also with the Ministry of Finance, and being able to support financing releases for use within immunization programs. So ultimately, we believe that these three elements of governance, accountability, clear targets and measurement, and advocacy are the things that have been really successful in our ability to see coverage move in these geographies. And I just want to show, I want to highlight the coverage, the Penta 3 coverage here in Olamami, and the fact that it's increased from 50% to 72% since RISP began. The second lesson I want to share is that these coverage gains can be fragile. You can see that in the last slide, you saw that Olamami's coverage was at 72% in the coverage survey that happened this year. And last year, in last year's coverage survey, you can see from this chart on the left-hand side of the graph that Olamami's coverage was at 95%. So we dropped quite significantly in the last year. And we expected that that would happen based on what we were seeing on the ground. So why did this happen? There were some external factors, such as changes in the government. There was less political prioritization of the Mashako Plan in the context of presidential elections, and there were some changes in the Piri schedules. But one of the things that our work had a direct impact on is in mid-2022, that's when we actually started to withdraw some of our technical assistance and ramp down our intensive support at the provincial level. And we think that this was probably premature and led to some of the declines in coverage. I also want to highlight another sustainability insight. On the right-hand side of the slide, you'll see the GDP per capita in the MOU geographies where we work compared to in Nigeria, which is what we kind of base this model on, based on our previous success in being able to co-fund operations with the government and have the government slowly take on more of that operation financing while we decreased our financing. And what we've learned since then is that, given the fiscal space of the geographies where we're now working, as well as I think the even greater constraints globally with the macroeconomic situation, it's not actually going to be possible to achieve the level of financial sustainability that we had assumed at the beginning. The third lesson I want to share is on our work in humanitarian settings. So in Somalia, most zero-dose kids live in hard-to-reach areas that should be serviced by the government. However, 30% of zero-dose kids live in areas that face chronic insecurity, and most of the people in these places haven't actually seen consistent health services in over a decade. And so through RISP, we've been facilitating a humanitarian partnership that aims to reach about 370,000 zero-dose kids under the age of 5 with an integrated package of health services. And I've highlighted the roles of many of the partners in this humanitarian partnership in the second column on this slide. And one thing that I want to highlight is within this partnership, we're actually working with the WFP innovation group to facilitate us within this humanitarian partnership. And they're not a prime grantee. They're sort of an equal grantee with all the other partners who are supporting logistics and service delivery, et cetera. But their role is really to act as a neutral facilitator to support our partnership to work well together. And that's one thing that we think has been really critical to be able to work within this complex humanitarian partnership in a really challenging setting. I'm going to highlight a little bit of the data that relates to zero dose and under immunized kids in our work in Somalia. Third-party monitoring has been another tool that has been really essential in humanitarian settings. Often the admin data is particularly weak in these settings. And so this third-party monitoring really helps us to understand whether we're reaching sufficient children. And then finally, one of the things that is really important is we always include the BESD questions or even some additional questions to understand the behavioral and social drivers of non-immunization. So this slide shows that on the left-hand side, you can see that even though we've identified a lot of zero-dose children, we haven't necessarily always reached them. And on the right-hand side, you can see data that shows us reasons for non-vaccination. And over time, you can see the number of kids who are not receiving Penta 1 is dropping. And also, we're starting to address some of the major barriers. So for example, you can see this bright purple that, when we first started in January and February, there was a lot of caregiver hesitancy about immunization. And we've been able to address that through demand side interventions. And you can see that proportionally that barrier to immunization is dropping over time. The fourth lesson that I want to share, and this is a little bit in contrast to what I just talked about with the Somalia work, is that working effectively in humanitarian and conflict settings is really challenging. And so we also have a similar program in the Central African Republic in Region 5. And Region 5 is about the size of the UK and has a population of less than 450,000. There are only 9 nurses in the entire area, and most facilities can't be reached by road. So supplies need to come in on humanitarian flights. You can see from the pictures on the right-hand side of the slide that, equipment lifetime in these places is really low. The cold chain needs for outreach are enormous. And we've actually really struggled to make progress in this area. Um, some of the quick insights that we've learned are operating costs are high. It's really challenging to find partners who can effectively work over the long term in these areas. And in places of chronic insecurity, we rely on deep community engagement and sometimes peace mediation, even to be able to access communities. I wanted to show this as a bit of a contrast to what I shared previously, that, even when we're able to make progress, it's really challenging in these complex environments. And finally, the last lesson I want to share is on our measurement approaches. Now, I'm a little biased coming from the MLE perspective, but one aspect of RISP is to deploy very rigorous measurement, everything ranging from program monitoring to routine immunization coverage surveys. We support RI coverage surveys, often co-funded with Gavi, actually, in most of the geographies where we work. And we are working on innovative approaches also. For example, we have a grant to support better methods for measuring coverage and identifying zero dose in humanitarian settings, for example. We're using some of the WHO's new Wiki analyses to be able to highlight gaps in opportunities for vaccination and help subnational geographies to change policies to be able to reach kids that they're otherwise missing. I'm going to just flash here, for the sake of time, a couple of the different measurement tools that we're using. For example, you can see here the RI coverage survey, RI coverage survey data from several of the countries where we've supported those surveys in the last year. We also use routine monitoring and vaccinator tracking in a lot of the geographies to better understand whether outreach is getting to zero dose communities. And finally, like I mentioned previously, we always include qualitative questions on reasons for non-vaccination. So the summary slide just captures those 5 core lessons that I shared from our work, and I will pause here and I'm happy to take any questions and discussion. Thank you.